In this video, we're going to talk about a few items that are in this PowerPoint that are more review related. The new information, such as the efferent tracts where we left off last week, we are going to talk about on Wednesday so that we can talk in person and have time to answer questions and really dive into those a little bit deeper. So we're going to skip through the efferent tract slides. And just as a reminder, somatic is going to be talking about the voluntary nerves and parts of the nervous system that we do have control over. We're going to dive into that a little bit deeper here in a second. Versus autonomic is going to be maintaining that balance, talking about the parasympathetic versus sympathetic, things that are outside of our control but very essential for staying alive. In lab on Wednesday, we are going to be going through testing the cranial nerves. In the next couple slides here is information that you need to know about each cranial nerve. You can follow along in your notes. You can look also at your lab handout for this week. And again, we will be testing these and talking more about them on Wednesday, but you do need to review them. When we talk about cranial nerves, we talk about sensory, motor, or both. And so that's the way you need to learn them. So just make sure that you go through these and review. You need to know sensory, motor, or both. You need to know what the function is. If you're saying that something is sensory, you have to label the sensory function. If you're saying something is motor, you need to label the muscles or the actions that that cranial nerve controls. And if you're saying both, you need to have both a sensory and a motor component. The connection to the brain is going to be the area at which this cranial nerve emerges, runs, or affects. And the effect of damage is going to be what happens if there's damage to this nerve. So again, you have the notes here in front of you. Cranial nerve 1. Look at your notes in person. You might have to fill out some of this information. And your lab also has a chart with this. Cranial nerve 2, optic. Both of cranial nerve 1 and cranial nerve 2 are sensory. 3 is motor. It's going to control the muscles that move the eyeball. So review this. You might have to pause this video to take notes. Again, we'll talk about these on Wednesday. 4, trochlear is motor. 5, trigeminal, sensory and motor. 6, abducens, motor. 7, facial, both sensory and motor. 8, vestibular cochlear, sensory. 9, glossopharyngeal, sensory and motor. 10, vagus, sensory and motor. 11, spinal accessory. We should be very familiar with this motor cranial nerve. And 12, hypoglossal. You need to know your cranial nerves by number and name, as well as the information that is presented on these slides. Just a little reminder, with this somatic nervous system, we have a motor and a sensory component. As the information leaves the spinal cord, you have the ventral and dorsal root, like we've talked about with that cross section. Outside of the spinal cord process or proper, you have 2 rami. So you have dorsal and ventral rami. This is going to have both sensory and motor information. We also have some information that's going to parts of the body that we don't really spend much time in physical therapy talking about. So for example, the dorsal or posterior rami are going to go out to the pair of vertebral muscles, the vertebra and overlying skin, especially in that thoracic area. And then ventral, anterior rami, intercostal muscles, muscles and skin in the extremities, and anterior and lateral trunk. The anterior rami, particularly, will form the cervical, brachial, and lumbosacral plexuses that we're going to talk about in a minute. And so here you can see how that information comes out of the spinal cord. When it creates the spinal nerve, that can travel for far distances before it separates. And each area is going to be slightly different, but just know that you do have sensory and motor information that does travel together to certain areas. And so a further breakdown on the spinal nerves, this should be nothing new. We talked about this last semester. 8 cervical, 12 thoracic, 5 lumbar, 5 sacral, and 1 coccygeal. As a reminder, C1 through 7 come out above. We have C8 exiting below C7 and above T1. So we do not have a corresponding vertebral body for C8, but we do have a C8 spinal nerve root. And then T1 and everything following T1 is going to exit underneath the corresponding vertebral level. As we talked about the other day, dermatomes are going to be sensory aspects that are innervated on the skin level by afferent fibers. We have introduced you in the past to the picture that is on the screen, which is much more linear and doesn't really show as much of the overlap. One of the things that we looked at in kinesiology as well as in this class is that oftentimes we do have a lot more overlap than this more simplistic figure kind of shows. And that's really helpful, especially when we have damage to an area. We will not see anesthesia unless there are 2 or more spinal nerves completely losing function. So anesthesia is the complete loss of feeling. If we only have 1 spinal nerve root affected, such as if there is just isolated damage, maybe from, let's say, in a surgery, they nick a nerve and it's only damaging 1 spinal nerve root, then you will possibly still have sensation. It'll just be altered because there is, again, that overlap in the area. So just as a reminder, we have our cervical plexus, which is C1 through 4, going out to the neck muscles. The brachial and lumbosacral plexus, we spend a lot more time talking about because it's going to innervate the large majority of our different muscles in the body. So C5 through T1, and then lumbosacral is going to be L1 through S5. That is broken down, and many times talking about lumbar portion supplying the thigh and sacral portion supplying the leg and the foot. This is a nice little slide here that just looks at that sacral plexus and it shows you the muscles that it's going to innervate. So just have a look over this. Now, brachial plexus, we've talked about this in the past. Remember that the brachial plexus is going to be a group of spinal nerve roots that leave the vertebra in from C5 through T1, and they come together and then divide out, come together, divide out in different areas to create terminal nerves. As a reminder, this is important to understand because if somebody has damage in one area, so for example, if they damage the median nerve and you know what nerve roots are affected, you can start to understand how dermatomes might be affected or myotomes. Additionally, if you look at it a different way, that only C5 was affected, if you know what terminal nerves are innervated by C5, you can also identify where the person is likely to have damage or impairments. If you pull out your lab, Neurolab 2, there is going to be on the 2nd, 3rd, 4th, and part of the 5th page, there is a station for going through all your brachial and lumbosacral plexus to revisit all of those terminal nerves, talk about what is impacted, how it's impacted. This is going to be for you to do. We have done this in kinesiology. This is a review. So we will not be doing this on lab on Wednesday. So please make sure you do this on your own. If you choose not to look at it, then you're going to see this again. So you need to understand this, and it's just you need to revisit it. Just as a reminder that there's many muscles that do receive innervation off the brachial plexus, but not from those terminal nerves. So those are listed here. You can see this if you look at this picture here. So for example, if you look at the medial pectoral nerve, which is kind of in the middle there, you can see how it comes off the brachial plexus, and it's not coming off in the area of the terminal nerves. So it is getting innervation from brachial plexus, but higher up before they become terminal nerves, and going out to the pectoralis major and minor. And so if you have damage closer to the spinal cord in, let's say, C8T1, you're going to see damage to medial pectoral nerve. But if that damage occurs closer to where you have the ulnar nerve and median nerve, you will, even though C8 might be damaged out there, it will not be damaged at the medial pectoral nerve. And so you'll still have pectoralis, major and minor innervation, but you might not see anything that's innervated by median and ulnar working correctly. These slides are the same exact slides from kinesiology. So please make sure you revisit this information. You might need to pause this video to make sure you can fill out this information. It is also on your notes for today's class. All right, looking at that autonomic nervous system and sympathetic versus parasympathetic. These are different areas. This picture shows some different areas that the sympathetic versus the parasympathetic is going to control and how it controls it. So have a look over this. So for example, if we look at parasympathetic, remember parasympathetic, rest and digest, feed and breathe, slows heartbeat down, constricts bronchi. You don't need your bronchi wide open if you're just sitting there breathing regularly. We increase the release of things like bile and it stimulates peristalsis and secretion so that we can have digestion occurring. Versus when we look at sympathetic, yes, we're going to say, hey, we want to speed up that heartbeat. We want to dilate bronchi so that we get the most air flowing as possible to get it out to our muscles that need to work in order to run from that bear, whatever it might be that's causing us to increase our sympathetic response. So sympathetic division is coming from thoracic and lumbar regions, causes vasoconstriction, and that is caused by norepinephrine. Parasympathetic, brainstem and sacral regions caused by acetylcholine. I like this chart because it shows, depending on what type of state that the individual's in, what is happening at these different organs and different levels. So make sure you have a look over this and understand why something might cause something to be increased or decreased. If you have any questions, let me know. But this should, again, be a review for you. In thinking about why this might happen, some of the things that do play a role are your cranial nerve 10, the vagus nerve, It does extend past the head and neck down into the trunk. It has some involvement in stimulating myocardium, which is going to be the muscle of the heart, as well as the smooth muscles that make up the lungs and the digestive tract. So, when we move between these states, we're sending signals, oftentimes down the vagus nerve. The hypothalamus plays a large role in regulating digestion, whereas the medulla has a large role in heart rate and respiratory rate. We do also have some reflexes that are going to be more prevalent when we talk about the autonomic nervous system. So, you've probably heard of baroreceptors before. These are going to be pressure receptors, just like a barometer. Not in healthcare related terms, is going to be looking at the pressure outside with weather. Baroreceptors pick up pressure within, and so the baroreceptors are going to help the autonomic nervous system control blood pressure. All right, kind of switching areas here and talking a little bit about injuries within the central nervous system. We talked the other day, and someone asked a question about, is there different types of nerve injuries, and how would you word this? And this is kind of where this comes into play. So, different terminology that you need to understand, as well as thinking about where nerve damage occurs and how it might affect the ability to regrow nerves, to regain sensation or motor control, and if it's even possible for those things to happen. And so, if you just look at kind of the basic cell and tissue type structure and what happens with an injury, as soon as we obstruct blood flow to that area, so whether it's from a spinal cord injury, whether it's from um, surgical injury, whether it's from stretching on a nerve, within minutes of the oxygen um, supply essentially being shut off and being able to take carbon dioxide out of the area, cell and tissue death is going to start. It does not mean that it's evident in ways that we are able to measure it within the first 12 to 24 hours. It does take time to be able to pick it up on, imaging, for example. 24 to 36 hours, the tissue becomes soft. It gets adenomous because we have that histamine response coming to the area. And eventually, that soft adenomous tissue is going to die if it's not getting proper blood flow to that area. So any necrotic tissue then becomes a cyst. So it gets covered in cells that create a cyst. And those are going to be those cells that we talked about the other day. So you might have some oligodendrocytes in the area. You might have some astrocytes in the area. Those macrophages are going to come in and start chomping up some of that dead material. And this area is covered by a glial scar. Now, glial scars are going to essentially stop the spread and control that damaged area. But unfortunately, it's oftentimes going to limit the ability to have function in that area. So the original function is going to be lost. If the axon is damaged, that's really when we start to see impaired function of that nerve or that bundle of nerves. So if the axon is undamaged or has minor damage, we will start to see some collateral sprouting, which means it's going to come up and around the area that is damaged and sprout additional axons, and hopefully be able to regain sensation or regain muscle control, whatever it is, in the long term. However, if you damage the axon completely, such as cutting down the tree in this instance, the picture here, you're going to lose function. So you can have small amounts of damage, for example, cutting off a branch, and you'll get some collateral branches that are encouraged to grow. But if you cut the tree at the tree trunk, you're not going to be able to have that tree anymore. Some terms that you need to be familiar with Mononeuropathy, and this is just going to be one nerve that is affected in the nerve lesion, versus a neuroma. This is going to be a growth or a tumor. Essentially, doesn't mean that it's cancer causing by any means, but like a growth of nerve cells. Peripheral neuropathy is going to be a peripheral nerve outside of the central nervous system in the peripheral nervous system has some sort of disease process. So it's dysfunctional, it's impaired, whatever it might be. So we might talk about a peripheral neuropathy being if you cut yourself really badly in your hand and you damaged a nerve, that would be a peripheral neuropathy. And then a polyneuropathy is going to have symmetrical dysfunction. It's going to be sort of diffuse, meaning it's going to be in the whole area and secondary to pathology. So, for example, if we talk about somebody who has type 2 diabetes, who has not controlled their blood glucose levels over time, they oftentimes develop a polyneuropathy where they start to lose sensation and motor function in their feet and then in their hands, and it spreads from distal to proximal. That's going to be an example of a polyneuropathy that is also a peripheral neuropathy. Within any type of nerve injuries, we can classify the level or the extent of nerve injuries with the next three terms. So, neuropraxia is going to identify a nerve injury that is the mildest form of injury. And the thing to know about a neuropraxia is that the axon is preserved. We see the nerve fibers and the nerve conduction is preserved. So if the axon is still preserved, and so is nerve conduction, then we're still able to pass impulses along through that nerve. So somebody might experience some numbness or pain, some diminished sensation or motor function. However, within a pretty rapid time frame in terms of nerve injuries, a matter of weeks, we see this reversed. And so we can see this with like a pressure injury. So, for example, if you were on crutches and you were leaning forward on your crutches in the brachial plexus area, in your armpit area, and caused pressure damage, you could have some momentary numbness and tingling, like your kind of like your arms fell asleep. But if you put that pressure there long enough, you could also have some recovery that might take a couple weeks really to come back. And that would be a neuropraxia. Very limited damage, just pressure on it. Versus an axonotomesis, this is going to increase in severity. We do see some damage of the axons, but the supporting structure, so like the myelin sheath, is still preserved. With this, some function may remain or be able to, not necessarily remain, but be able to recover. However, if we see distal Wallerian degeneration, which is a type of nerve degeneration that starts distally and moves proximally, we will not see spontaneous recovery. So we really want to try to support an axonotomesis type of injury so that the distal Wallerian degeneration does not occur, but it might. If we start to see recovery, nerve cells will grow and or recover at 1 millimeter per day, starting at the spinal cord or the damaged area, depending on the type of injury, and working out to the periphery. So if you imagine you have a spinal cord or spinal nerve, let's say spinal nerve root C8, kind of near your scapula, between your scapula and your spine, if the injury's there. You have to go 1 millimeter per day all the way out to your fingertips. It would take a very long time for spontaneous recovery to occur. Now, in an instance of axonotomesis, there are surgical options available because those supporting structures are still intact. They can actually go in and surgically fixate that nerve back together in a more supported way. But it's not to say that they will always do that. Some types of injuries that are common: traction, compression, or crush injuries. So, crush injuries and compression are just kind of what they sound like. So, something heavy, really heavy fell on your legs, causing nerve damage, versus a traction. You would see this a lot of times in like sports. So, for example, if you are a running back and you go to catch a football and you outstretch your arm to catch that football as you sort of jump and somebody hits you, or you fall on that outstretched arm, you can cause a traction injury to your brachial plexus. So, pulling type of injury. And then the last or most severe is going to be neurotomesis. When we see a neurotomesis, our axon, the myelin, all of those tissues that help support and structure that axon are going to become damaged or severed. This is irreversible. So even if they try surgical reattachment, it does not always work. Now, you have probably all heard of instances where somebody has cut their hand or part of their hand off. They were able to save the finger and surgically reattach it. Um, it takes a very long time for nerves to grow in that area. Even when they try to surgically reattach them, you still have to rely on 1 millimeter per day of sprouting of new paths for that area. And it does not always mean that it's going to come back with the same function. So we will see flaccid paralysis, muscle wasting, total loss of sensation because it's not getting nerve impulses, it's not getting the blood flow to the nervous system. And so we see that permanent impairment. There are, again, sometimes where through a long recovery, we might be able to get altered sensation or motor function if it's a surgical type of procedure, but that original function is completely lost. I also have some definitions of some terms that we're going to be talking a lot about throughout the semester that you may not have really heard of before, or you have heard of but don't really know the true definition. And one of those might be spasticity. And with spasticity, the thing that we're talking about is high tone, high muscle tone. Now, all of you have muscle tone. If you didn't, you'd be like limp spaghetti, a limp wet noodle in your arm, let's say. But your biceps, your triceps, all your muscles have a tone to them. In the instance of spasticity, that tone of the muscles, the ability to kind of stretch and contract, is going to be high. So hypertonia. But the thing about this, and I don't have this underlined, velocity dependent resistance to stretch. If I move somebody with high tone slowly, I may not kick in their spasticity. But as soon as I move them quickly, their spasticity will kick in and it will generally stop the ability to move that body part. So, velocity dependent resistance to stretch. So, in individuals who have a lot of neurological conditions or neurological impairments, we oftentimes cannot move them fast because we will cause their muscles to spaz up on us. You've probably already all have heard of hyperreflexia. So, those are going to be the over exaggerated reflexes. And the most kind of severe form of this is going to be clonus, which we talked about the other day. If somebody has flaccid paralysis, they're going to have weakness, they're going to have paralysis, inability to move, they're going to have low muscle tone. So you're going to see kind of that wet noodle type of appearance. You're not getting innervation to that area, causing them to be flaccid. So the bones will be there, the joints will be there, but there's not really anything else controlling that area. Hyporeflexia is going to be slow or sluggish reflexes. Muscle atrophy is when we start to see the muscle decline, the tone in the muscle decline. We get muscle weakness, and then we also get the muscle itself has a noticeable diminishment. So you don't have the bulk there. A fasciculation is whenever we get muscle twitches that are uncontrollable. So you might probably have all had like a twitch in your eye before, and that's a type of fasciculation. In our patients who have neurological conditions, we can see this happening regardless of, if you're stressed and your eye twitches. So your eye twitching is going to be a benign fasciculation versus if you have twitching and tremors due to things like Parkinson's disease, which is going to be related to pathology. When we talk about nerve injuries, we can also classify them as either upper or lower motor neuron injuries. And you will see this labeled as UMN injury or LMN injury for upper or lower motor neuron injury. When we talk about upper, we're typically talking about conditions that occur within the CNS. So the pathology itself is happening within the central nervous system. These individuals will typically present with spasticity, hyperreflexia. They will have a positive Babinski in adulthood as well as clonus versus somebody who has a peripheral outside of the central nervous system injury. We usually see flaccidity, muscle atrophy, muscle fasciculations, and hyporeflexia. These are some examples of upper versus lower motor neuron lesions that we're going to be talking about throughout this semester. Some conditions are going to be what we'll say is both, and we'll talk about those throughout the semester, that they have examples or they have characteristics of both upper and motor neuron lesions. So these would be some really great topics to look at for your research paper. If you haven't looked at that yet, start thinking about that. All right. If you have any questions, please let me know.